Thanks so much, Pete. And hi, everybody. Thanks for joining us. Glad to see so many people able to call in. I'm not sure how many people were able to catch last week's presentation or how many are joining today because they weren't able to make last week. But I think the feedback that we've received has been really tremendous. And so I think you're in for some really helpful information and a treat just with the clinical expertise that we have all across this phone, frankly. Both presenting and listening. So I'm Alex B. I'm the Assistant Secretary for the Office of Public Health, and just want to kick this meeting off by saying, the goal here is to share what we're learning, what our intensivists are learning in high volume sites across the state about really the most effective way to treat critical patients with COVID-19. Early on, which really is only a little over a month ago, when we were sort of seeing such a surge in patients, so many people sick, and really critical resources like ventilators beginning to be consumed really rapidly, I was reaching out quite a bit to Bud O'Neill at the lake and talking with him about lots of things, including what kind of retrofitting we can do to BiPAP machines and things like that, just to get more vents out there. And he and Flip Roberts from the LHA really sort of keyed me into talking with many of the intensivists who you'll hear from today, David Janz, Stephen Brierre, Chris Thomas, folks on the phone who had really been seeing higher volumes and had begun to take measures to apply best evidence to these specific patients in a tailored way that really was showing, early, by the last couple of weeks, reduced numbers of people having to be on ventilators, shorter length of stays on ventilators. Most importantly, mortality impacts are going to be the key thing that we want to drive with all of this. And so really wanted to get them out in front of as many people as possible, especially across our state, because we know that if you're in a lower volume center, you may not have the opportunity to learn quite as much as this team did from the early days when they just had lots of people coming around. We were asking them to set up whole additional ICUs. I'll note as we're moving into this next phase, as we're talking about reopening, as we're talking about restarting the Louisiana economy and restarting even just starting next week with time-sensitive surgical and medical procedures, I think we're all going to be watching very closely to see how things go in the hospital, but also what happens to case counts around the state. And we are not out of the woods really until we've got an effective vaccine, which could be quite some time from now. So I think this message is just as useful this week as it was last week, as it was when I first heard it a couple of weeks ago. So without any further ado, I really want to turn it over to the experts to talk to you about what they've learned, and I think provide you an additional resource in your care for COVID patients that are critically ill going forward. And thank you, and thank them for their time in putting this together.
Hey, this is Bud O'Neill. I'm going to give a little bit of an introduction here to what the purpose of this collaborative is. Originally from small town Louisiana, DeRidder, and so have kind of a vested interest in what goes on in the lower volume centers. I also know the quality of physicians and nursing staffs that they have in those facilities, and I think that they can really execute a lot of the things that we do in the higher volume centers. So we wanted to focus on throughout this collaborative, focus on what we consider to be the best executable practice for the smaller volume centers. We're going to talk about things that are predominantly physician and nursing behavior driven, protocol driven, things that don't take any special machines or special expertise, just really sticking to the guidelines and sticking to the knowledge that we have about caring for the critically ill. I think it really applies to this patient population. And with that, I'll let Chris take over, and we'll go from there.
Thanks, Bud. So I am Chris Thomas. I think each of us will introduce kind of our backgrounds and then walk through it. I am a pulmonary critical care physician by training, part of LSU Healthcare Sciences Center in Baton Rouge, and then the medical director for patient safety and quality for FMLHS Health System. Our goal here was to try to provide some key insights and then to have them, as Dr. O'Neill said, an executable. So what I'll start with is initially a proning protocol. Most of you on the phone have understood that utilization of proning on patients on a ventilator has been a useful tool for us, but is one that can be complex. One of the things that the disease has taught us is that some changes and improvement to oxygenation can be done on non-intubated COVID-positive patients, and in particular, when you're using such devices as an OptiFlow or a high-flow nasal cannula, sometimes referred to as well by the trade name of Vapotherm. So we've seen improvements in overall oxygenation in patients when they become prone. That's based off a Perceiva trial in intubated patients. And in this disease, an ability to facilitate not intubating them, we've talked about using these patients in a protocolized fashion to, if they can, prone themselves. And so I'll try to hit the highlights of the documents just so you can see the ones that are really germane to your practice. But essentially, patient eligibility is someone who is awake and can be conversant with your team, someone who needs less than 30 liters per minute, and then someone who doesn't have what would be a contraindication where if they became acutely ill, you wouldn't be able to come into the room and help facilitate them needing to potentially be intubated. And so those are things like no evidence of hypercapnia, and in specifically, this disease requires a multidisciplinary approach. And so the things that we've learned is by using the physician, the nurse, the respiratory therapist, that patient eligibility part number 7 is really critical. So your teams have to agree that the patient's a good proning candidate daily during your interdisciplinary rounds, and then to be able to operationalize that process. You can immediately see improvement in saturations on the patients for who it's valuable. The protocol is pretty easy. Ideally, you would go 16 hours a day and 8 hours off. The patients can prone using a pillow as a headrest. And then during these bundled care assessments, the nurse or respiratory therapist should wear the PPE for helping those patients if they need some assistance. So the patients can stay proned if they're asleep, and then they supinate themselves when desired. Also germane to this is the ability to stop proning. And in those, the 2 keys is that the patient requires a significant amount of oxygen, greater than 30 liters, and has desaturation to less than 88% during proning. Probably the activity should be cessated and the patient should look for an alternative intervention. We have learned in this disease to tolerate lower oxygen saturations in our patients than we did traditionally. But when you consider the concept of proning, you need to make sure that our typical traditional care delivery happens to a patient in the supine position. So sticking to that 88 and looking at the oxygen in the proning perspective has proved to be a valuable when to stop. There's also on there a video primer about proning. It looks specifically in intubated, but it's hopefully for the groups and teams. And these patients can be asked to do this very early in their hospitalization. And that's what our experience demonstrates, that if there's a benefit, that would be the location and time. I'll move from that then to if these patients are unable to maintain off of a ventilatory support. And we've seen a nice reduction here in the Baton Rouge market, about a 20% reduction in using ventilators by doing some of the things that we've learned in combination with David Janz at UMC New Orleans. We also then decided that one of the issues that you have to address is the idea of analgesic sedation. And this is in a bundled care model. So where you may not have your traditional ICU nurses, or you might have a low volume where you have to get assistance if you get 3 or 4 of these patients. The other consideration within this document is just about resources. One of the things we realized quickly is that if you get a significant volume of patients, a significant volume of pharmaceutical resources will be utilized, particularly in the critically ill. So having an understanding of where current state is, and then being able to identify how you would take care of these patients with medicines. And so in this document, what you've seen is the idea that we should stay to our standard work. That's a spontaneous awakening trial with a linked spontaneous breathing trial that Dr. Janz will talk more about in the next section. But specifically how you should target their sedation and what kind of medications we could typically use. In tier 1, that would be all resources available. As the disease itself penetrates certain markets, also has the potential for clusters and nursing homes. The potential is you might not have all of your resources. And then we moved on to a tier 2 where resources are limited. And the ability to think about where your target is, again, generating what you need to what you need to do to take care of the patients, but also thinking about second line agents and almost what we'd say is not really well described in the literature, but what could be the next step for you and your teams. Obviously, every patient needs control of pain, and then the question is the potential need of whether or not they need either a GABA agent. Traditionally, we use propofol, or if you're out of that medication, maybe a secondary agent such as a benzodiazepine. And then tier 3 and 4 are really reserved when the above resources are unavailable in lower volume centers. This also might be the time when anticipating that the patient's volume has gone up to try to help facilitate our teamwork around the state in terms of using other facilities, but also to look at crisis standards. And so this is when you don't have what you typically would use to take care of an ICU patient, and then what are the available alternatives in COVID-related acute respiratory disease. And so we tried to be as inclusive as we could to provide a framework. We've not had to get into a lot of these medicines, but during the peak here, both I think in New Orleans and in the Baton Rouge markets, we've had strong considerations of where the literature is and what medicines would be available to help facilitate our patients. The third document that I'll talk about as well is revolving around ventilator, clot. Along with that document on analogous sedation is one for all the teams if you don't have large ICUs, which explains all the mechanisms, all the things we talk about in terms of the medicines in general, but the elimination, so whether they're renally cleared or liver, and so that's really a resource document. And then we'll move over to the COVID VTE management. We hope by the end of the day to be able to upload another updated version here for the collaborative. But the underlying background here is that traditionally in patients who are critically ill, their VTE risk is somewhere between 2 to 6%. We try to mitigate that risk by utilization of chemical prophylaxis in the critically ill. What our experience has been over the last 6 weeks is that these patients are at high risk of venous thromboembolic disease. And so the question for us has been, how do we prevent that kind of manifestation, but yet also recognize some of the risks related with full anticoagulation. And so this document here is what we believe to be an evolving practice, but at current state, what we do for our patients in terms of prophylaxis. And what you'll see is an elevated enoxaparin that mimics almost the bariatric trauma patients. I can also tell you in full disclosure that this management style matches that of Johns Hopkins and other places around the country that are seeing it. And then the other part to point out in this document is just who from a pharmacotherapy in this disease, if you don't have access to ultrasounds or others to identify that there is a clot, who are these people that we're seeing clinically might show parameters that say, hey, I'd be concerned about venous thromboembolism, and then accordingly PE. And what we've seen is persistent fever, a hypoxia that initially improves but then declines unexpectedly. So patient on the ventilator day 4 and all of a sudden needs an acute increase in oxygen up to 60%. And then in particular, we are patients who have obesity and we're on the ventilator. It goes along with immobility. Also on the non-ventilated patients who are critically ill using BiPAP and using high-flow nasal cannula, the amount of immobility that those patients have also presents a more elevated risk. And so we have both enteral route and not having the enteral route available. And so looking at the newer agents as well. And that's, again, more of a resource allocation. So if you get a large amount of patients, you have typical patients in your hospital who are using Lovenox or another kind of low molecular weight heparin for prophylaxis. The other conversation is in treatment of do you have enough resources in chemical and can you use some of the newer agents? And so we provided that guidance as well. And I'll stop with that. Those are the 3 documents that we'd like to start with. And I will toss over Dr. Janz in New Orleans, and he can talk through his experience in terms of the critical care primer and the considerations.
Great. Thanks to Chris and everyone else, and thanks for all the people that are on the call. In New Orleans, we got our first patient in the ICU on March the 10th. And then our response to this, since we got a lot of patients that came in, we quickly started developing a couple of different critical care treatment protocols. for these patients, assuming that our experienced intensivists would be pretty busy with lots of patients, and that we may actually have some non-traditional critical care providers taking care of patients. And so we needed something to hand to people to say, do this general type of care for the COVID patient who gets admitted to the ICU. And specifically what you see on the screen here, this is our general type of care for the COVID patient that's intubated in the ICU, and is based on a number. This is basically just a summation of a number of large randomized trials that have occurred in critical care over the past couple of decades. A summation of those data on one sheet of paper in regard to taking care of the ARDS patient who's on the ventilator. On the left side of the screen, you can see this is in regards to prone positioning. We use prone positioning, and the evidence would suggest we should use it in the setting of a patient who has severe ARDS, moderate to severe ARDS, with a PF ratio of less than 150. Sometimes it's difficult or time consuming, or you're just too busy to get lots of blood gases. And so here's a rough rule of thumb on the screen of a degree of hypoxemia that basically would give the patient a PF ratio of less than 150. So if you see that arterial oxygen saturation on that much FiO2, the patient's sick enough that it would be an evidence-based intervention to provide prone positioning. We prone patients, one of the things we learned pretty early on is that proning a lot of patients, if half or most of your ICU needs prone positioning, this is a resource utilization issue, and it's not quote unquote a free intervention. It does require one or two nurses, maybe one or two doctors, a respiratory therapist to prone a patient, which if you're only proning one or two of your ICU patients, it's not a big deal. You can easily watch a video on how to do this and do it well. But if you're proning 12, 14, 16 patients a day, and every nurse is busy in the ICU, every doctor is busy in the ICU, it becomes a big resource issue. So a legitimate concern here is, first, before you decide this therapy, is do you have people in the ICU that just can come help and do this procedure? Maybe having a central line in prior to prone positioning, because definitely if the patient is then put in the prone position and then you realize they need a central line, it makes everything much more difficult and requires the patient to be turned again. So maybe placing a line before you flip them. A rough rule of thumb is prone them overnight. So in the evening around 4 p.m., prone them, and then in the morning when most people return for work in the day, put them back supine, and then keep this going as long as they're basically that sick. And once they're better, then you can stop proning. Second column here is some recommendations on fluid management. Maybe one of the most commonly misunderstood parts of this fluid management strategy here that I get the most questions about is people saying or asking, should they ever give fluids to this patient? And the answer is yes. So if when these patients present to the emergency department, if you detect some sign of marked hypovolemia, they're in shock, they have some obvious measure of fluid responsiveness, et cetera, something about them suggests marked hypovolemia, you should volume resuscitate that patient. That would be appropriate care for that patient. Lots of these patients have been sick at home for the past week or so, not eating and drinking that much. It makes sense that they'd have hypovolemia. All these recommendations below are basically, as the hours and days go on in the ICU, it perhaps is not appropriate to continue volume resuscitating that patient and to continue fluids on and on. In fact, that would likely make their ARDS and hypoxemia worse. Here are some recommendations about these patients as the ICU days are going on and on, about giving Lasix to these patients, perhaps the patients who are not in significant shock on high doses of vasopressors. And finally, if Lasix is ineffective, you may need to do intermittent hemodialysis or continuous renal replacement therapy. The ventilator management is basically the same ventilator management that you all already know about in the care of the ARDS patient. giving reasonable tidal volumes, and if the patient has moderate to severe ARDS, using higher amounts of PEEP. On the right-hand side of the screen, here you can see whether or not COVID testing is positive or negative, doing daily SATs and SBTs, and trying to achieve light sedation in these patients, especially if they aren't that hypoxemic, as Dr. Thomas already talked about, not staying them into a coma, and hopefully extubating them as soon as possible. And then my next slide, my next algorithm is on the next slide. If we can advance one slide. I'll have to figure out how to erase all of my marks on this screen. 1 second. This is the first time I use this, so I'm not, oh, here's an eraser. Let me erase all this so it doesn't confuse you. This slide is now the patient who you've intubated for their COVID ARDS. You've made them better. You've been successful at improving their hypoxemia. And now you're wondering, should you extubate the patient? Here at the top of the screen, what we've seen pretty early on is very few of these patients look that good when you let them spontaneously breathe on spontaneous awakening and breathing trials. They all are almost all tachypneic. They commonly desaturate. And if they don't, then that's the left-hand side of your screen there, where if they look great on a SAT and SBT, then you should extubate that patient after a brief breathing trial to a nasal cannula. So if everything looks fine, extubate them as you normally would. That doesn't commonly happen with these patients. They usually have some amount of distress during these breathing trials. And that's where the middle part of that algorithm tells you some advice, where we basically give them more pressure support and PEEP on their spontaneous breathing trial if they're failing that trial, until they start to look better on that spontaneous breathing trial, not to keep them intubated, but to know what BiPAP settings we're going to extubate them to. And then we extubate them to what we have been calling closed circuit BiPAP. If the patient just floridly fails their spontaneous breathing trial, meaning they develop some life-threatening complication, like significant desaturation, worsening shock, tachyarrhythmias, etc., then that patient has just failed their breathing trial, and you should try again tomorrow. And in between now and then, keep working on stuff to make their hypoxemic respiratory failure better. One note about extubation of these patients is extubation is an aerosolizing procedure. So the people in the room during extubation should be wearing N95 masks. And ideally, the patient should be in a negative pressure room, but at the very least, people in the room should be wearing N95 masks for this procedure. And that is it for my part of this presentation.
Great, thank you. Next, we'll hear from Dr. Bud O'Neill.
Hey, well, Bud O'Neill again. I guess I didn't introduce myself earlier. I'm a pulmonary and critical care physician with LSU Health Sciences Center in Baton Rouge at both ldh.la.gov and Baton Rouge General Hospitals. And I wanted to talk real quick about N95 mass sterilization. What we've seen over the last couple of weeks is that one of the major limiting resources that we have in our possession is the N95 mask, especially the small size, which many of our team members wear. Because of this, we've looked at a sterilization process, and I have the process for that we use in our institution here up on the screen, and also available in the file catalog that we have is the STERAD and STERIS procedures for sterilization of these processes, as well as a Duke University trial that looked at these. Now, it's important to understand that STERIS and STERAD say that you can reuse these masks up to 10 times or so, I believe. And the Duke University study looked at that and found that they could use them many more times than that. Now, in our facility, we will reuse them up to 4 times. Another important thing to note is that in the STERIS and STERAD emergency use authorization that they received from the FDA, they try to reuse the same mask for individual patients, but in a large facility such as ours, the same providers, but in a large facility such as ours, that becomes very cumbersome. In the Duke study, they found that they will maintain their fit after several reuses, and so it's not necessary to label those with the name of a provider unless you want to or you feel that that's necessary to do, but they will maintain their fit. I should say too that ultimately in all of these procedures, it seems that the limiting factor was that the elastic bands tend to degrade with multiple reuses. Now this is well into the double digits of reuse, but you can see here on the back of our mask, we put tick marks for the number of times that we have sterilized the mask, and we will reuse them up to 4 times. But we could certainly go more than that if it were necessary. We can go on to the next. The next slide. So the next slide that we have is the treatment support document. So this just looks at predominantly pharmaceutical treatment that we have for this disease. And I think that overall our group, the group that put all this together, our consensus is that there is no documented efficacious treatment for this disease. A lot has been said about hydroxychloroquine, about azithromycin, about certain antiretrovirals, but none of them have been proven to be efficacious. And our concern is that anything that's not efficacious is potentially harmful, especially with cardiac toxicity of things like hydroxychloroquine and azithromycin. This document is here to say that if for some reason, despite that, you do choose to use one of these medications, these are the dosing strategies that we would recommend, and takes into account both toxicity and conservation of the medications. But I think overall, I would say that outside of a clinical trial, you should use these specific medications with caution. Otherwise, typical supportive medications such as acetaminophen and albuterol for symptomatic relief are just fine. We typically try to use MDIs when we can because of the potential of aerosolization associated with nebulized treatments.
Thank you. Next, we'll hear from Dr. Brierre.
Critical care, Baton Rouge General Hospital. The first document that we're going to look at is ICU quick tips for the medical surgical nurse. For many of y'all, as you surge in your capacity, you'll have to adopt a buddy nurse program in which you take a critical care nurse and pair her with a floor nurse or a surgical nurse to increase the capacity of the critical care nurse and change staffing ratios from 1 to 2 to 1 to 4. When you do this, you'll be placing a floor nurse or a surgical nurse in a position where she's titrating and responsible for medications which she does not use on a daily basis. Given that, we wanted to create a primer which would give her some certain clues and points to watch out for when using these medications. In the first page of the document, we list the medications used for invasively mechanically ventilated patients. Again, building on what both Chris and Dave talked about, that analgesia and sedation will be necessary for your invasively ventilated patients. We've broken the drugs into the analgesic medications, the sedating medications, and then given recommendations relative to paralytics. Recognizing that all the therapy that you're using for angular sedation in invasively ventilated patients should be targeted therapy. We briefly discussed the RAS score, which has been discussed several times already. It is a good idea for the ICU nurse to double check the floor nurse who is beginning or titrating these meds. Included in the primer is the starting dose, the maximal dose, and some common side effects. We won't go through each of these. Moving on to the next part of the document, we get into positioning and what is proning. And Bekah Booth, one of our ICU nurses, is here currently just to give a couple of quick tips relative to proning, since we have discussed it already 3 times from a nursing perspective.
Hey, I'm Bekah Booth. I'm a critical care nurse at Baton Rouge General. So the main thing with the proning policy, since what Dr. Brierre pointed, we have a lot of non-ICU trained nurses acting as ICU nurses right now. So we have a policy that can be used as a pretty good step-by-step guideline. Ideally, this policy calls for respiratory therapy at the bedside to be securing the endotracheal tube with 2 nurses or staff members, really whoever is available, even nurses' aides, this can be accomplished with nurses' aides at the bedside. So 2 people on each side of the bed and 1 at the foot of the bed, calling out the policy step by step. Before you start moving the patient, everyone should know their role in the process. Who's holding the endotracheal tube, who's holding the central lines, making sure they're not rolling underneath the patient. And then only 1 person should be calling out the steps of the proning, just to avoid any confusion and going over each other. We're always going to turn the patient towards the ventilator for proning and away for supine. Once the patient is prone, you want to place them back on telemetry and check pressure points right away. You want to check the ears, the nose, the mouth specifically, and you want to make sure no cords or IV lines are underneath the patient. Just something that's been helpful for us so we don't exceed the proning time of the 16 hours is putting a little note on the whiteboard or the door of the patient of when the patient was proned and whenever they should turn supine again. That's pretty much what I have for that.
Awesome. We can move on to the next document, which will be the use of PPE and just some general recommendations. Simply put, anytime you're encountering someone with an influenza-like illness, even if they have not been confirmed COVID positive at the time, they should be, healthcare professionals should be in droplet precaution attire, which will include a surgical mask, eye protection, gowns, and gloves. N95 masks, which Bud talked about conserving as a resource and how to do that, should be used during any aerosol generating procedure. We've listed what those procedures are. Dave has already talked that extubation is one. Obviously, intubation and bronchoscopy are also one. The ones that may not be appreciated are patients who are non-invasively ventilated, patients who are on high-flow nasal cannula, and patients who are receiving nebulized therapies. Also, there should be caution whenever you're doing anything which may generate a cough to the healthcare provider, such as repositioning of endotracheal tubes and things like that. Relative to the patient, if the patient has an influenza-like illness, we want the patient to decrease how much they can transmit whatever virus may be present within them. And so if it is possible for the patient, you should have the patient don a surgical mask to prevent them from coughing on healthcare providers. Negative pressure rooms are obviously ideal, and if you aren't hitting surge capacity, you may be able to pull this off. But I'll say within our facility, negative pressure rooms were gone within the first day of identifying our first COVID patient. And with that, I'll pass it on to Brad for comments on ICU structures.
All right, thanks, Dr. Brierre. It's Brad Vincent here, critical care, Our Lady of the Lake. I'm going to talk briefly about a little bit about the structure and an overall function of your critical care unit with regards to PPE and just general flow. So first, we're going to talk about conservation of PPE. And the idea is to obviously conserve, not ration, but conserve the amount of protective equipment that is available to your healthcare providers. And that basically means just being smart about who needs to be in contact with the patient and for how long and how often. First thing is to, and we learned this because of the rapid influx that we had in mid-March, but basically having to construct COVID-specific intensive care units and be smart about how we did it and where we did it. One of the early lessons we learned was about how to get these patients from the emergency department to your ICU with the fewest or the least amount of exposure possible to both other patients and healthcare workers. One of the ways that this could be done is basically to have a COVID-specific code or moniker that gets designated to the patient. The house manager manages the flow of those patients from the emergency department to the ICU. Same with the floor transfers. But the the ultimate responsibility lies with the source of the patient, both either the emergency department or the hospitalist, to make sure that PPE rules are being followed. Another couple of areas were phlebotomy. So the nurse does the bedside draw for those patients with a central catheter. We allow blood draws through the central line. And then the clean runners take handoff to the lab. Same with radiology. We minimized greatly the amount of x-rays that were done in the COVID-specific ICUs. And then pharmacy, obviously, clean runners bring the drugs to and from the COVID unit. I'm going to talk a little bit about the COVID unit structure. So the main principles, the overriding principles, are that you really want to cohort or cluster your COVID patients to the same unit when possible, and that's based on your specific facility or institution. It's going to be difficult in some places, easier in others, but you really want to maximize your ICU capable spaces before you have to convert non-ICU locations. And then you have to coordinate with your physical plant services to understand the limits of your facility, both architecturally and geographically. But basically, each unit is going to consist of an anteroom, or, if possible, also with a locker room to change into scrubs. You have a scrub cart there as well as a sink. You'll have the shoe and head cover. So it's going to look a lot like an anteroom for like an operating room. And this should be separate from your visitor or common entry if possible. Next, you have a common entry where visitors come in and out if allowed. Patient transport occurs through this entry and exit. And you want to make sure that you minimize potential interaction with the patient care space. Next, you have a PPE zone where you don PPE, and it should have, in some places they're using basically a bucket of disinfectant with rags that are changed every so often. The PPE is contained here. And then you have the dirty zone. It's a bit of a pejorative term, but we've sort of separated into dirty and clean, quote unquote. But the dirty zone consists of patient rooms, your medication dispenser, your computer workstations. One of the considerations is that you should at least think about designating a single workstation per provider to avoid cross-contamination. And then even physicians and mid-levels should even consider bringing in their own devices if it's possible to interact with your EMR. In the clean zone, we have the supply room, the bathroom, break room, or kitchen. And here's one area that is of special interest, and that's actually a topic of food. So, there's a lot of people in the community who want to donate food, donate meals, restaurants, etc. And it really has to be done correctly. There should be no common items like serving trays or catering trays, if possible. Things should be individually wrapped. No more than a couple of people in the kitchen or break room at any one time. And it's, I think, a good idea to designate a hospital representative to coordinate with your food donors in the community to give them specifications on what you want and to better facilitate getting your team fed. The transition zone between clean and dirty areas, is where, pass off for medication and supplies. In most of our units, it's basically a table or a couple of tables with signs labeled, to designate what items go where. This is a pickup point for clean runners and a drop-off point for labs, etc. Tube systems basically should not be utilized. It's generally a bad idea to spread virions through your tube system. The main principle as far as patient care with regards to PPE and reducing exposure is to minimize contact. So minimize patient room entry for non-direct patient contact. So in order to do this, we moved IV pumps outside of the room, if possible, ventilator control panels outside the room. We did this early on, and MRI tubing was essential in helping with this. MRI tubing can be sort of squished in a door and still function. Next, I'll just briefly talk about our COVID unit, standard operating procedure for don and doff of PPE. So your personal items passed off to the clean area, hand hygiene on entering the unit, you don your gown, and most of our units, we have just non-disposable gowns that are laundered. You don your gloves. These act as your clean hands and a surgical mask. You cover your clean gloves with your dirty gloves. You remove your dirty gloves after your patient encounter. And then if you're transitioning from the, quote, dirty zone to any of the clean or transition zones, then you have to don or you have to doff your full PPE as not to cross-contaminate. This is just sort of an architectural mock-up of sort of a typical ICU with the pink areas being considered dirty, the white areas considered clean, and the blue area there, which is your transition zone, which again is typically a table or a series of tables with labels for your items. Next, we're going to talk about just briefly touch on conservation of your healthcare capacity. So considerations would be just to sequester your healthcare worker to a specific unit, minimize entry and exit to avoid contamination of clean spaces. Checkout should occur electronically, not in a common area with other people coming on service or off service. Have covers for your bags, phones, laptops, etc. Only take essential trips or travel within the hospital. Kind of plan your route accordingly, and try and take the stairs. Avoid elevators because elevators are sites of, I think, frequent contamination. For nurses, have a buddy system to visually monitor proper donning and doffing procedure and to spot possible contamination events. And there's some sample buddy tasks there that are listed, which you can read. The last thing I'll talk about is conservation of blood products, limiting blood draws. One of the things that it really taught me being early on in taking care of these patients is how many unnecessary labs we order. Same with radiology, how many x-rays we order just because a patient's intubated. That really doesn't change our management. And all it serves to do is to basically have a source for potential exposure to the radiology technicians and to other patients. As far as conservation of ventilator time, we've sort of already touched on this. I think the only other major issues to consider for your specific institution would be ACLS, who to code, when to code, and who not to, and early involvement of palliative care in a lot of these patients. And with that, that concludes my portion.
Great. I just want to thank everyone, the presenters so far. We'll now move into the Q&A, so feel free to put it in the chat or go ahead and unmute yourself. And while you're thinking of questions, I'll start with one that we got in the chat. Probably for you, Dr. Bud O'Neill. Does the N95 sterilization process include an autoclave, UV light, ozone? What's the optimal material?
Yeah, so the most studied is going to be a hydrogen peroxide vapor procedure. And those are outlined in pretty good detail in those documents.
That makes sense. Any other questions from folks on the call? All right, if there's no questions, any takeaway points from our presenters?
Yeah, I'll bring one up. I think teamwork is integral to delivery of this, of the care to these patients and the disease. I also think that it's really important early in the process to make sure that you establish where your victories are and celebrate them. I think there's some trepidation and fear related to the care and delivery of a patient who has the virus, and there is some assumption bias that the patients won't do well. What we've seen over the past 6 weeks is that as some of these patients improve and ultimately go home, that recognizing that along your teams creates a general sense of pride and allows the teams to interact in a way, particularly in the methodology that Dr. Brierre talked about when you're doing team-based care, that allow each of your members to feel a true sense of both responsibility and success in the care delivery. So what I would say is, as you advance in thinking about who your teams are going to be taking care of COVID patients, that you make sure that each part of that team is celebrating the victories and understand how critically they are. We have recognized, I think, that our environmental service technicians prior to COVID in our facilities were under congratulated and maybe didn't have as much positive coming from the clinician side as optimally we probably in retrospect should have. And so those members of each of these teams are absolutely essential. So while we talk oftentimes about physicians and nurses, your therapy teams, respiratory therapy specifically, and then as you move into physical therapy and occupational therapy, and then mostly your environmental service technicians, those groups need to be understood how critical they are to actually save the life of someone with this disease. And I think that's a really big, important part for each of your facilities to recognize those. It's a lesson we learned within probably about 3 weeks, but one that I think is really important as you move forward in terms of care delivery of these patients.
This is Stephen Brierre. I'd tag on to the team thing. Remember, also in your teams, you're going to be dealing with other physicians. Some will have trepidation coming into the ICU that may be unfounded, but it'll be present. We have to lead by example. In two components of leading is N95s are indicated for aerosol generating procedures only. And so I don't walk around with an N95 mask in my COVID units trying to lead by example. Also lead by example in protecting your patients. Strict hand hygiene is important in everything you do. Finally, regarding physicians, work with the providers who are going to be working with you. For us in our facility, that's been the ER and anesthesia, and we've been communicating with ER every day and trying to develop processes which decrease burdens on both their labor force and PPE usage, as well as our own. Communicate and be helpful. It's a different time right now. It will be easier if you do that.
I have another question. have y'all heard anything about this, about a theory about the virus's effect on actual oxygen carrying capacity for hemoglobin, or nothing?
Yeah,
Well, anyone can take this call. I assume we're talking about the article which made it analogous to carbon monoxide poisoning.
I think that's fair. I'm not sure the poster's question, but
yeah, that's out there and mostly in social media. It was based on a single observational sort of computer model. So it happens what's called in silico, and that means it happens in the computer. And so we have now good autopsy data from both New Orleans and Oklahoma, I believe, are the two that I've seen published, where there's no evidence that actually happens in vivo.
thanks. Looks like that's the questions. I think that brings up a sort of takeaway that I've heard y'all say over and over again, which is there's no silver bullet. It really comes down to good evidence-based and careful ICU management. And just want to thank you guys for building the tools and resources to help get that out, especially places that are lower resource and may not have the experience of the major urban centers. So we'll get this recording uploaded to the LDH website. Those resources, again, are available at ldh.la.gov/ccresources. And feel free to email me at pete.croughan, that's CROUGHAN, @la.gov with any additional questions, and I'll make sure it gets to the members of this collaborative. Thanks, everyone, for taking the time, and take care.